Hi, and thank you for taking the time to view this presentation. I'm Dr. Vidales Benitez or Oscar Vidales Benitez. I am a pediatric psychologist at Dell Children's Medical Center, and I'm also an assistant professor at the Dell Medical School with the University of Texas at Austin. I'm also one of the clinicians in the T-Chat program, and today I'll be providing an overview of non-suicidal self-injury or NSSI. Specifically, I'll be looking at assessment for this behavior, as well as a brief overview of intervention that can be provided for it here. Here is a brief overview of the primary objectives for the presentation. So we'll start off by defining non-suicidal self-injury or NSSI and differentiating it from other forms of self-harming behavior. We'll also talk about the risk factors often associated with NSSI, and then we'll discuss key elements in NSSI assessment and intervention. So I want to start off by getting us oriented to what we're talking about today, and specifically to what we are referring to when we use the term NSSI. I do want to specify that I'll be using NSSI, self-injury, and non-suicidal self-injury interchangeably throughout the presentation today. So when you hear me use any of those terms, I'll be referring to this specific behavior. So NSSI itself is defined, as you see on the screen, as the immediate and deliberate destruction of one's own body tissue without suicidal intent and not for purposes that are socially accepted. So when we talk about self-injury, we are not talking about things that are socially accepted, like tattoos or piercing or behavior that kind of falls along those lines. We're also not talking about other more general forms of self-harm. Oftentimes, the word self-harm is used to describe self-injury or NSSI, but self-harm is more of an umbrella term that can also include other behaviors like substance use or eating disorders, for example. So today I'll be more specific and I'll describe this particular behavior that we see on the screen as I said already, NSSI, self-injury, or non-suicidal self-injury. I want to start off by giving us an overview of what NSSI is like. More specifically, I want to talk a little bit about onset and prevalence. So basically, when this behavior is typically seen in youth, as well as how often it is observed or seen among youth. So data out there indicates that when we talk about onset, so specifically when this behavior is typically first observed, there are two major trends that tend to emerge. Specifically, we know that there tends to be an onset of the behavior in early adolescence, so between the ages of 11 and 15, and late adolescence between the ages of 17 and 18. There's different ideas as to why this behavior is typically seen to start or begin during these two time frames within the life of youth. But one of the more common ideas put out there is that these time periods, these age ranges, tend to be those associated with high transition for early adolescents and for later or older teens. If we think about it, that age range of 11 to 15, typically the middle school years, there's a lot of change and transitions, both within the school system, right, going from elementary to middle school to high school, as well as other forms of transition, both developmentally, biologically, and socially for young teenagers. The other end of the spectrum, that 17 to 18-year-old range, also associated with a lot of transition, graduating from high school, going on to work, going on to college, or other changes along that way. So it's hypothesized that that stress that comes with change and transition may at least partially explain why the behavior tends to have an onset during these times. Regarding prevalence, rates generally indicate that this behavior is most seen among teenagers, with rates varied. So there are rates that indicate that anywhere from 10 to 25% of youth engage in self-injury at some point in time, with the most commonly cited number being about 23%. So maybe about 1 in 4 youth or 1 in 5 youth will indicate that they have engaged in self-injury at some point in their life. The numbers and the differences in these numbers more specifically is oftentimes indicated to be associated to how the behavior itself is explored. And we'll talk a little bit more about how our assessment of the behavior can give us a different response rate to it here. Of those who do endorse engaging in self-injury, about 1/4 or about 25% of that 23% that I mentioned earlier report engaging in the behavior repeatedly or more than once or more than at one point in time. One topic that is often discussed when looking at NSSI generally are differences seen across populations, and there's emergent data across different subgroups of teenagers. But one of the most often discussed topics is that there is a general trend for self-injury to be more often or commonly seen among girls or females. So data, though, also indicates that this is a more complex picture than just that. So even though rates are higher among females, about 8.5 of adolescent males also report having engaged in NSSI at some point in time. Some of these differences, though, can at least be partially explained with, again, how we assess the behavior itself. So typically, when people think about self-injury, they oftentimes think of cutting, which is more often seen in girls or females. So there's this hypothesis out there that when we assess or ask about self-injury, if we ask a more general question like, do you ever or have you ever self-injured, that we're more likely to get responses from girls who are in fact more likely to engage in that type or that form of self-injury. Males, on the other hand, are more likely to engage in different forms of self-injury, including being more likely to punch or hit themselves with an object. So there are some people out there who indicate that that 8.5 that we see in males reporting self-injury may actually be higher if we were to ask more specifically about other forms of self-injurious behavior. There is also data to show that this gap is typically more present, right? The difference between males and females and the prevalence of the behavior among these two subgroups is more present during the earlier years and tends to narrow down in late adolescence. So rates are more similar among older teens. There's also evidence out there that rates of NSSI are more common among LGBTQ plus youth and specifically among transgender youth, but there is still emerging data that's coming out in that way here. So another piece that I want to make sure we talk a little bit about today is helping gain insight and helping understand why youth self-injure and specifically things that put youth at risk for this behavior here. I do want to specify that there is no single cause or profile that will tell us if somebody is at risk for engaging in self-injury, but there are certain behaviors or characteristics that have been found among this youth subpopulation. More specifically, one of the most common and consistent findings is the presence of emotion regulation difficulties, basically difficulties managing strong emotions or having emotions rise in intensity very quickly is often seen among this youth population or among youth who self-injure. Similarly, many youth who self-injure also report higher rates of mental health difficulties or the presence of a mental health diagnosis. So things like anxiety, depression, post-traumatic stress disorder, substance use as well tend to be common among these youth. Another common finding that's seen to be a risk factor for self-injury are interpersonal difficulties. So youth who self-injure tend to report having more difficulties with coping with interpersonal difficulties, more difficulties with communicating effectively and problem solving effectively. So interpersonal problems seem to be more common among these youth as well. as is a history of suicide attempts, right? So there is evidence and data out there to show that kids and teens who have a history of suicide attempts tend to be at higher risk for engaging in self-injurious behavior. Another piece to understanding youth who self-injure is knowing the reasons behind this behavior itself or the function that NSSI serves for these youth. Many youth who self-injure struggle to specify a reason for engaging in this behavior, and others who do report a reason actually end up reporting multiple reasons that oftentimes change with time. So functions are complex and should be understood, keeping a psychological, social, and biological factors in mind. So these can really be varied from case to case, but what I have on screen is a brief overview of some of the most commonly cited or identified reasons or functions for engaging in self-injury. By far, the most common reason or function for self-injury are for purposes of emotion regulation, or what we call intrapersonal reasons. So about 53%, about half of youth who self-injure indicate doing so to help reduce, manage, or escape negative emotions. So basically using self-injury as a way to provide some kind of emotional relief, even if temporary, when uncomfortable emotions are present. Although less common, some youth report engaging in self-injury as a form to express self-hatred or as a form of self-punishment. Other youth, especially youth who are pretty heavily depressed, will report engaging in self-injury as a way to reduce feelings of numbness, or to quote what I have heard some youth say, is doing so to help feel something, right? To get rid of that sense of emptiness that may be there, especially like I mentioned already, with pretty severe or significant depression as well. Less common, but at times indoors, is using self-injury as a way to avoid suicide. So some youth will indicate that they use self-injury as a way to avoid engaging in suicidal behavior. I underline that here in the presentation, and we'll talk a little bit more about this later on. But whenever this is reported as a reason for engaging in NSSI, that will send up red flags on my part and will indicate a need for more immediate intervention or more immediate action. Social reasons are also reported. These are less common, but are also at times described by youth who engage in self-injury. So some youth will engage in the behavior itself as a way to seek help from others, to communicate feelings of distress. One thing that I've heard at times from providers or from parents as well is that they will at times see self-injury or have heard of others seeing self-injury as a way to seek attention or to be attention-seeking behaviors. This is actually not often the case. Actually, most youth who self-injure do a pretty good job at hiding the behavior. So whenever the behavior is discovered, it tends to be by accident, somebody catching a glimpse, a friend noticing something going on, a teacher noticing something going on. So most youth actually don't use self-injury as a way to seek attention from others, as opposed to some of the other reasons that we described here. So like I mentioned, the reasons or functions can be really varied from youth to youth, can oftentimes change with time, but oftentimes getting an indication as to why this behavior is occurring for youth, if they're able to specify, can give us a good idea as to how to provide even immediate intervention, right? What to help youth work on to help reduce the frequency of this behavior here. The last piece that I'll talk about here before we get into more specifics about assessment and response is differentiating NSSI or self-injury from suicide. The association between these two behaviors is oftentimes misunderstood. It's happened to me on multiple times that youth will have NSSI be discovered or seen by somebody at school or by a provider, and then that person will assume that this isn't a suicide attempt, or that this is in some ways associated to suicidal behavior, which it doesn't necessarily have to be the case. It is nonetheless a concerning behavior, but not always indicative of suicide, right? We need to have a more thorough assessment to sort those pieces out. There are several differences between NSSI and suicide, despite the behaviors being similar in some ways. First, NSSI is less lethal and rarely requires medical attention, especially when compared to suicide. NSSI is more prevalent than suicide, it's more common than suicide, and is also more frequently seen in youth than suicidal behavior. NSSI, however, is a risk factor for suicidal behavior. So I often advocate for NSSI and exploring self-injury to be a part of a suicide risk assessment. And because these two behaviors are different, it's important that they be understood, they be managed, and that they be treated differently. And that's oftentimes what's advocated in a lot of literature regarding self-injury itself. So what are some things that are important to keep in mind when we discover or find out about a youth behaving in NSSI? I do want to validate that having NSSI be disclosed by a youth or coming across NSSI in youth, regardless of our relationship to them, whether it's in a clinical setting, whether it's in a classroom, whether it's a friend who uncovers or discovers this behavior and then comes over and tells us, it is difficult to find out that this is going on. It can be scary to find out that their youth is engaging in this behavior. But oftentimes the initial response that youth have from a trusted adult, from a caregiver, from a teacher, from a school counselor, from a school social worker or provider or therapist can paint the picture of what future intervention and what disclosure can look like. So just a couple of things to keep in mind, some do's and don'ts right here. Don't, for example, be overly reactive. Don't try to stop the behavior itself. Don't promise confidentiality, and don't discuss the behavior around peers. So the counterpart of those would be things that we would advocate for. So things to do is to accept the student, even if we don't accept the behavior itself. Do use student language, so model or mimic what the student referred to their behavior as. If they call it self-injury, then call it self-injury. If they call it cutting, then call it cutting, right? Try to model or follow the student's lead when they talk about the behavior itself. Do show a respectful willingness to listen, and also show non-judgmental compassion when speaking to the youth in this behavior here. I do want to specify and validate, as I mentioned already, that finding out or seeing or coming across or having this disclosure happen around self-injury can be difficult to manage, but knowing who to go to provide support is going to be key in making sure that these students are receiving the support that is necessary to help address this behavior and this concern. With that in mind, right, I do know at times that the responses that may come out more immediately from us as either a teacher, a form of caregiver, or a counselor or a therapist may be at times difficult to contain or keep kind of calm, but I strongly advocate for these things that we see here on the screen, right? Keep in mind how our response or initial response, especially among people in schools who may end up being the first person to come across the behavior itself or a disclosure of the behavior itself, can really paint a picture to what future responses can look like for this kid and how this kid may respond to other people seeking to explore or assess that behavior and provide some kind of support in some way. So with that then in mind, one of the key takeaways and one of the most important messages that I hope to you all take from this presentation is that when we are screening for NSSI, we use a low-key, dispassionate demeanor and a respectful curiosity. And this often happens in the form of validation, right? So we want to validate our students' emotional and behavioral experiences. And I think none of us really intentionally try to come across as judgmental, but this can happen at times with the approach that we take in exploring this behavior with the youth that we work with. One of the best ways to prevent poor responses from providers, and in order to make our kids feel more safe and comfortable, is to, as I mentioned, follow these kind of guidelines for our interpersonal style when exploring this behavior, regardless of the setting that we are in. So something that I oftentimes advocate and recommend as part of any clinical interview is to have a thorough assessment of non-suicidal self-injury or thorough screening of the behavior itself. So what I'll go through in the next few minutes will be what's called the SOURCE model. SOURCE stands for an acronym, which we'll discuss in detail in a bit. And this is the work of Dr. Nicholas Westers out of Children's Medical Center in Dallas and UT Southwestern. He's a psychologist off of that site that I got a chance to train with during my fellowship years. And he has a really great model to assess and explore self-injury and to help determine sort of next steps when we discover this type of behavior. The first part of the model itself is, have you ever hurt yourself on purpose without intending to end your life or attempt suicide? I'm thinking of things like cutting, biting, burning, and hitting. I want to point out a couple of things. For one, is that we are differentiating NSSI from suicide, right? So we are indicating, have you ever tried to hurt yourself without trying to end your life or attempt suicide? And then we're also being specific, right? We're giving examples of what we're talking about: cutting, biting, burning, hitting, among others. So in this way, we try to kind of provide a broad question, right? Asking about self-injury, but being specific and giving examples of different behaviors that we are trying to assess or trying to explore about. I want to say that it is okay to ask about this behavior. We are trained professionals in doing so here, and that there is no danger in doing so. What you see at the bottom part of the slide right there is the SOURCE model itself, and we'll go through each of those letters here to talk about what kinds of questions can help us gain more insight into what steps to take when self-injury is disclosed. So the first part of the SOURCE model, the S right here, is specifically looking at suicidal ideation. So the wording for that is exactly what you see here on the screen. I know self-injury isn't about suicide, but some people may think about suicide when they self-injure. Do you ever think about purposely ending your life when you self-injure, right? So this one here is asking, like, is the NSSI or is the self-injury tied to suicide as well? If the response we get to this here is yes, then doing a more thorough suicide risk assessment would be very, very important. And then following up by using the school's suicide response protocol and looking at all other factors that we typically assess for when we're assessing for suicide would be really, really important. As I mentioned already, it's important for a trained mental health professional to be the person conducting this kind of assessment, whether it's on NSSI or suicide itself. From there, the O of the SOURCE model stands for onset, frequency, and methods. So we're looking at a couple of things right here. There's three parts to this part of the model there. So the first couple of questions, the first few questions, we're actually trying to get an estimate of how often this behavior is occurring. So we want to ask, when was the first time that you self-injured, right? Getting a rough estimate of when that happened. And then asking, when was the most recent time that you self-injured? That can give us a good time frame of how long this has been going on for, right? With earlier onset, right? Earlier onset, maybe in the early teenage years, late childhood years, being indicative of higher risk associated to suicide. But when we have a good time frame there and then follow up with how many times a week or a month do you self-injure, that can give us an indication of how many times a youth has self-injured in their life. So getting a good time frame here of the first versus the most recent episode, and then the number of times that it's happened typically in that time frame can give us a good indication as to how often this kid or this youth has engaged in this kind of behavior. From then, following on from here, have you found that you have begun to self-injure more often or more deeply than when you first started? If a youth responds yes to that, that to me indicates that there is a need for more severe NSSI to happen, for a youth to get the effects of that behavior itself, and increases the risk that this youth may have for engaging in more severe behavior in the future, or also for engaging in suicidal behavior instead, right? So seeing that this is happening more often, seeing that this is happening more severely or more deeply would be concerning from a clinical standpoint. What have you used to self-injure will be the next question, and what typically do you use? So if we are told, right, that a child has multiple forms of engaging in self-injury, or he has multiple methods for doing so, those again would be elevated risks or elevated concerns clinically, and as well as if there are different ways to engage in similar behavior. So for example, knowing that scratching is different than cutting, and youth who engage or describe both of those behaviors would have increased risk versus one who engages in one versus the other, and things along those lines there. So basically, the greater number of methods that are described would be indicative of greater risk and more clinical concern regarding this youth's functioning and general well-being. The other parts of the model are described here as well. Aftercare, or A in the model itself, the two questions here to ask would be, how do you typically take care of your wounds afterwards? Like, what do you typically do to take care of wounds after you have self-injured? And have you ever hurt yourself so badly that you could have used medical attention, like stitches, even if you never got it? Right, so there's a couple of things to keep in mind. So what we're looking at when we talk about and ask about aftercare is actually looking at severity. How bad is the NSSI? Is a kid, for example, using a napkin and dabbing their wounds afterwards? Are they kind of cleaning them out with water, just more superficially? Is there significant bleeding that happened, right? Which would obviously be concerned. Do kids need significant bandages after they self-injure, which again would be a significant concern clinically regarding safety, regarding suicide risk, for example, would be elevated if that were the case. Is youth at risk of infection, right? Like, was there a need to see a doctor, but that didn't happen, for example? All of those would be indicative of greater risk for suicidal behavior and greater concerns for safety as well. So again, we're kind of piecing all these pieces, all this information along the way as we try to assess next steps regarding this behavior here. Reasons, right? Notice how the wording here is. It sounds like this has been helpful for you, right? So we're validating the experience, even if we don't approve or condone the behavior itself. In what ways does it help you, right? What is this doing for you? Would be another way to assess and look at that question here. So getting insight into reasons, which is the R part of the model, can give us ideas for potential brief intervention, right? So what it allows us to do here is to validate but not condone self-injury through that wording that's offered in the model itself. Remember what I mentioned earlier, right? That if a reason for engaging in NSSI is to avoid suicidal behavior, then that would be an increased concern for safety for this kid and would warrant more immediate intervention by a mental health provider. If reasons are indicated to be for self-hatred, for punishment, those would also be indicative of greater risk for suicidal behavior and would definitely be very clinically relevant information collected from the child here that would warrant more immediate interaction and more immediate efforts in that way. The final stage, or S, of the source model itself is regarding stages of change, right? Trying to assess and explore where our kids are at regarding the behavior itself. Have they tried stopping before, or are they something that they're wanting to stop? So the questions then would be, is this something you would like to stop? Have you ever considered stopping, right? This can help us gain insight into the readiness that these kids have for engaging in alternative forms to have their needs met, and can also give us some outlook as to what would make sense to recommend clinically as far as intervention by a mental health provider, or in the work that we're doing if we are mental health providers ourselves in our settings. So again, a couple of things here to keep in mind. The source model is intended to be a screener or a brief screener for self-injury. The different pieces of the model itself can give us insight into a number of things, including the level of risk associated with the behavior itself. As I mentioned already, there are several pieces here that would definitely raise red flags on my part and would tell me that more immediate intervention is needed. Specifically, as I mentioned, if there is concern for more significant engaging in self-injury, if the reasons there are to avoid suicide, for self-punishment or self-hatred, those would be things that would definitely make me concerned and would warrant more immediate intervention. The question of disclosing this behavior to parents oftentimes comes up. This can be very different within clinical settings or mental health settings versus a school setting. So what I would say there is to follow school protocol, right? Talk to the person that typically leads these conversations with families. And it's really dependent on a school by school and case by case basis. Right? So I would hold back from offering sort of recommendations in that way because it really ends up being school dependent and specific to the protocol that's followed within the school. I'll have a resource up at the end that will offer information on school protocols for NSSI behavior and will offer good insight into recommendations offered in that way. I know schools have different policies regarding the behavior itself and disclosure to families in this way here. But as I said already, following that school protocol would be really important in determining how to best move forward and when to involve parents. So here's a brief overview that's provided by the source model regarding intervention for NSSI and specifically brief intervention itself. So really what the model itself advocates for is that intervention be really sort of geared or focused specifically on the responses that are offered regarding reasons for engaging in NSSI. So for example, if a child discloses that they engage in self-injury as a way to reduce emotional distress, that may be indicative of a need to identify alternative strategies to provide that emotional distress. So working on developing coping skills, right? Working on developing alternative ways to achieve that emotional distress would be really helpful. Looking at relaxation strategies, for example, would be a good way to go. Creating a coping skills inventory would be a helpful way to go about with these children. There's numerous resources out there that can more specifically talk about these strategies here, but this would typically be the way to go. Again, as I mentioned before, the idea here would be that these could be more immediate or brief interventions, but obviously getting consultation, connecting these kids to a licensed mental health provider would be the most highly recommended approach to take to make sure that we are setting up these kids to have their needs fully met by somebody who's trained to provide this type of support and care. Similarly, if a reason disclosed for engaging in NSSI is to reduce emotional numbness or to feel something, identifying alternative strategies would be the way to go here. So things like, for example, taking a cold shower, right? Splashing our face with a little bit of cold water or iced water can be helpful too. Some creativity can oftentimes come into identifying alternative strategies for any one of these behaviors here, but problem solving and involving our kids or students can be helpful here in gaining their insight to see if anything else has provided this kind of relief or provided this kind of experience for kids outside of the self-injury that they've been engaging in. And then finally, if the reason to engage in the behavior is said to be to communicate with others or for more of those social or interpersonal reasons, then similarly identifying alternative strategies. So asking for support, talking to a friend, talking to a parent, going to a counselor, things along those lines can be helpful ways there, right? So finding ways to more effectively communicate would be the more immediate brief intervention that can be offered in the moment here. As I mentioned already, right, this is a brief overview of some simple interventions to try out with kids who disclose engaging in NSSI, but ultimately connecting these students to a licensed mental health provider would be the most appropriate way to go to making sure that we are keeping our kids safe and are providing them with appropriate care and meeting their needs. So with that in mind, here's again, just a brief overview of some of the information that we discussed here. So I want to say that NSSI is prevalent even among non-clinical populations, as I mentioned already. The reasons or the functions for engaging in NSSI are varied from kid to kid. getting insight into the reasons for engaging in this behavior can really provide us with good insight on how to best support youth within a clinical setting. The primary function, as I mentioned earlier, is for emotion regulation, right? This tends to be a common problem among youth, kids, children who self-injure or engage in self-injury. Similarly, as I mentioned already, NSSI and suicide are different behavior and thus warrant different types of responses and intervention. Compassion and respectful curiosity are key and essential approaches when responding appropriately to these concerns among youth. As I said earlier, assessment of the behavior is critical for a good response, and the source model by Dr. Westers that I described earlier is a very effective and helpful tool to have when exploring this behavior if we are mental health providers. And as I mentioned earlier too, teachers and school-based staff are key players and frontline workers really in the identification of self-injury. So I appreciate each of you taking the time to listen to this presentation and hopefully learn a little bit more about NSSI assessment, about NSSI treatment or brief intervention too. I do want to say that oftentimes kids that I see in clinical settings had the first disclosure of the behavior to somebody in a school, whether it's a friend, a classmate, whether it's a teacher, a counselor. Somebody in the school was typically the first person to find out about this behavior here. And so making sure that our school staff feels comfortable around these disclosures is very important. And that comfort can oftentimes comes from even just learning about the behavior, which I hope is a takeaway from this presentation here. So again, thank you for taking the time to listen to this talk and presentation here. I hope some of the information here was helpful and there are some takeaways as well. The presentation itself is not intended to replace thorough and more extensive training in this topic here. And I do want to offer resources that are available out there. So here is several sources that I used for my presentation throughout, including the work from Dr. Westers out at Children's Medical Center in Dallas. The article that I mentioned that it provides really good insight about school protocols in response to NSSI is the first one listed here under my references. It's a great resource that's available that provides a pretty thorough overview of the behavior itself and also provides an overview of resources and approaches to take in responding to NSSI in the schools. Similarly, that third article listed here by Nicole and colleagues also does a really good job about describing protocols to take to responding to NSSI in the schools. I also have some recommended resources, some online resources, as well as books and books for parents of youth who self-injure. These are great resources to have, especially for providers who serve these youth or mental health providers who serve these youth. And I wanted to make sure I listed them here so that they could be available to you all if there's an interest in that way. Please don't hesitate to reach out. Like I mentioned, this is a very short, brief, concise presentation of a very complex topic and a very complex behavior in youth that warrants further attention. But I appreciate each of you taking the time to hopefully learn a little bit more about NSSI. And I really hope that the information here was helpful to you all. Like I mentioned, I'm Dr. Vidales Benitez. Please don't hesitate to reach out if any questions do come up. And thank you again for taking the time to learn a little bit more about self-injury or NSSI. I appreciate the work that you all do, and I appreciate you taking the time to find ways to better support your students. I hope you all have a great school year. Thank you so much.